I want to welcome everybody to our webinar Wednesday. And today's webinar will be Functional Endocrinology Testing, Why I Measure Urine Cortisol with Dr. Deb Matthew. My name is Amy Paoletti, and I'm a member of the Dutch Education and Marketing team, and I'd like to thank everyone again for taking time to be with us today. We know we're all kind of in this new normal with the COVID pandemic, and we know that many of you are operating your clinical services virtually, and taking care of your patients is essential for their overall individual and collective health. We also realize testing plays a vital role in your practice. For anyone listening who might not have an account with Precision Analytical, I'd like to invite you to consider setting up an account with us. You can go to our website or become a provider form. You can also call our customer service team. We have an awesome, great opening order offer for any new provider that comes to Dutch, receiving up to 50% on an order of 5 or less kits. If you're not familiar with what Dutch stands for, if you're new to us, Dutch stands for Dried Urine Test for Comprehensive Hormones. We offer simple and convenient collection for patients. We have unique test results that help clinicians understand the patient's hormone health. Additionally, we have an outstanding clinical consulting team, always available to answer questions from clinicians about patient results and possible treatment options. I wanted to go through just a few housekeeping items before Dr. Matthew starts. We'll answer as many questions as possible at the end of the webinar. So please send your questions via the question section in the lower side panel of your screen. We'll try to do that the last 15 minutes of the webinar. And I want everybody to know if you miss anything, don't worry. We do plan to send the recording, the on-demand recording, as well as all of the presentation slides to you within 24 hours after this webinar. Urine cortisol is going to be our key topic today with Dr. Matthew. She measures urine cortisol on almost all her patients, and she's going to review several patient case studies with you today. I've personally had the pleasure of working with Dr. Matthew for the past 10 years or more, as she completed her fellowship in anti-aging and regenerative medicine at A4M, as well as a board examiner with A4M. Dr. Matthew is a leader in the field of medicine and has proven level of knowledge repeatedly. Not only completing A4M's advanced fellowship and board exams, she has also successfully completed the American Board of Integrative Medicine boards. She has presented lectures about hormone therapy to forward-thinking doctors across the U.S. as well as internationally. She has been the president of the North Carolina Integrative Medicine Society since 2015 and is a member of IFM. She is the author of the best-selling book, This Is Not Normal, A Busy Woman's Guide to Symptoms of Hormone Imbalance. And finally, she is the founder and medical director of Signature Wellness in Charlotte, North Carolina. So please welcome Dr. Matthew.
Well, thank you for that. My forwarding isn't working. Can you make it so that I can forward my slides again?
Hang on, Dr. Matthew.
So while we're getting all of this straightened out, with all of this pandemic going on, all of our adrenal glands are really on overdrive. And so this is kind of a timely topic for us to be talking about right now.
Can you try now?
Yep. No, it's not going.
It's not going.
Oh. That just went back to the beginning though. Did I do that?
No. There you go. I may have to advance them for you.
Okay. So we're talking about stress today. And one of the things I think it's important to clarify is when we talk about stress, we mean emotional stresses like the slides don't work when you're doing a presentation, or marital stress or financial worries, all those kind of emotional things that we know about, but also physical stresses. So injuries, back pain, physiologic things like insomnia and allergies, and chemical stresses like, the toxins in the environment. So sometimes people are very well aware of their stresses, like their back pain, and sometimes we have no idea, like if you're living in a home with mold. But all of these things nonetheless are still counting together to add to our stress level. Can you do the next slide? Amy? Oh, so here's our challenge, is that according to the American Institute of Stress, stress is not a useful term because it is so subjective. So it's very hard to define. And if we can't define it, then how can you measure it? And so it makes it very difficult scientifically to be able to study, measure, quantify. But we do have a way, and one of our ways of quantifying is to do a cortisol test. Next slide. So of course we have our HPA axis. So when our brain senses stress, we release corticotropin releasing hormone to the pituitary. That releases the ACTH, which tells our adrenal glands that it needs to make cortisol. It all works on a negative feedback loop, and that's great when it works. But of course, as we're going to talk about, there's a whole bunch of things that mess up this very delicate system. And so we want to be able to make sure that this system is working properly. Next slide. Stress and HPA axis dysfunction is so common. So my practice, my niche is hormones. So most of the people who choose to come and see me believe that the reason that they're tired, can't lose weight, feel flat, whatever their symptoms are, they believe it's probably because of a hormone problem. And most of the time they think it's menopause or they think it's thyroid, but in fact, the #1 hormonal problem that we find is a problem with HPA axis. So every doctor sees people who has this problem. It happens for people in all ages. We even treat children with this problem. It doesn't matter your socioeconomic background, everybody has this issue. And the problem is that it's just not recognized or dealt with. So when you have chronic stress, it promotes disease. And when you have chronic disease, it promotes stress and HPA axis dysfunction. Next slide. We know that most chronic disease has stress as an underlying causative factor. So when you have more stress, you're at greater risk for things like asthma, insomnia, etc. But also, all of these chronic diseases promote stress and HPA axis dysfunction. And by no means is this an exhaustive list. This is just a quick list of the kinds of chronic things that are associated with HPA axis dysfunction. Next slide. We know that cortisol is very important. If you don't have enough cortisol, like Addison's disease, you have a whole list of symptoms. We'll talk about some of them later. But excessive cortisol from chronic stress is a wear and tear hormone. It ages us prematurely, causes weight gain, especially around the midsection. And really importantly for us right now in what's going on with us today is it has a negative impact on our immune system. So cortisol is a regulating hormone. It regulates your sex hormones. So people have more menopausal symptoms, perimenopausal symptoms, PMS symptoms, etc. when they have a cortisol problem. Cortisol helps regulate thyroid function. So a lot of people will have thyroid symptoms with normal thyroid labs, and it's because it's not their thyroid gland's fault, it's an HPA axis problem. Cortisol regulates sleep-wake cycles, it regulates blood sugar, and really importantly, it regulates our immune system function. Next slide. Can we have the next slide? Okay. So we know that stress is a strong risk factor for type 2 diabetes. Next slide. We're just going to go through these slides pretty fast. Stress is a major risk factor for heart disease, and I've got some more slides coming up in a little bit to talk about that. Next one. Stress activates our innate immune system. So that's a really important factor because right now our innate immune system is our first line of defense against this whole coronavirus. And for the people whose innate immune system can't get a grip on the virus, then days later, then they end up with the cytokine storm and their immune system is overreactive. So exposure to stress activates our immune system even without exposure to a pathogen. Next slide. And the way that it works is we have these danger-associated molecular patterns, or DAMPs, that get activated when there's stress, and it triggers an immune response. We have similar ones that recognize microbes and other factors. So it's a really important concept to understand that you don't have to have a pathogenic infection. You don't have to have a pathogen to activate our immune system. Stress and HPA axis dysfunction is one of the things that can promote inflammation. Next slide. We know that stress is associated with less natural killer cell cytotoxicity. We know that it declines, that it causes a decline in secretory IgA levels. And secretory IgA are the antibodies that protect our mucous membrane interfaces with the outside world. So the lining of our eyes and our nasopharynx, and really importantly, the lining of our digestive tract. So when we do stool testing, we can measure SIGA levels in our gut. And it's a common thing that we find for people who have HPA axis dysfunction, that their SIGA levels are actually depressed. And the end result is we get an imbalance in our gastrointestinal microflora. So stress can mess up our gut bugs. Next slide. The other way around too is that our microbiome affects our HPA axis. And in fact, they found that infants with dysbiosis end up having changes in how they respond to stress going forward across their lifespan. Next slide. So our microbiome regulates our HPA axis, and our HPA axis regulates our microbiome. So if you are treating people with gut health issues, thinking about the HPA axis is a really important piece of helping them to heal. Next slide. We can even see that when we use prebiotics and probiotics and support the gut microbiome, that it can actually help to normalize the HPA axis. So when we have somebody with an abnormal HPA axis who's not feeling well, we do also have to think about their gut health when we're trying to help them get better. Next slide. Neuroinflammation goes up when we're stressed. So that's the same, stress increases inflammation, so including in our brain. Next slide. And of course, we know that brain inflammation doesn't necessarily cause a headache. It causes brain fog and fatigue and anxiety and depression and poor memory. So we can see that there are specific effects on our brain from inflammation. And we know that this stress-derived inflammation is one of the many risk factors that can promote Alzheimer's. Next slide. We know that depression is associated with changes in HPA axis functioning. It can be associated with elevated cortisol levels, and especially with flatter diurnal curves. Next slide. We know that stress actually increases the rate of shortening of our telomeres. And of course, the length of your telomeres is sort of a marker for the health of your cells. And there's even a suggestion that stress in the newborn setting sets the length that your telomeres start with. So if you've had a difficult intrauterine environment, you may start your life off with shorter telomeres. So it's an interesting idea. Next slide. So let's get into talking about why would you want to test somebody, because that's really what we want to talk about. So I want to talk about the testing, what our choices are, and then we'll go through some different cases. So I test cortisol in almost all people that come into my practice. And what I find is that most people who come in to see me share very similar symptoms. They're tired, their mood is flat, they don't cope with stress well, they don't sleep well, they're bloated, they can't lose weight, they've lost interest in sex. I mean, we hear the same things over and over and over again. And typically we're doing a comprehensive approach. So we're trying to look at all sorts of different factors that affect them. We want to know about their hormone balance. We want to know about their gut health. We want to think about toxin exposure and detoxification. We want to think about lifestyle habits. And what we find is one of the most common things that is a factor for most of the people that come in is a problem with their HPA axis. So when we test for it and when we measure it and when we show them on a piece of paper, it helps them to, first of all, validate how they're feeling. Because I say a lot, like if you came in and you had big purple blotches all over your face, every single person that you met would say, oh my goodness, what's wrong with you? How are you feeling? But if you just don't feel good and there's nothing to really see on the outside, sometimes it can be difficult, and you sort of feel like maybe it's a personality flaw, or your spouse starts to wonder what's wrong with you, like why don't you just get up and get moving. So showing on a piece of paper that there is an actual real problem here really helps validate how people are feeling. And I feel like people really like to see that. That's not really a reason that Blue Cross Blue Shield necessarily would want to pay for a test like this, but I do think that it's important. And then it can help us to identify the physiologic effects that stress is having on their body. So it gives us a way to measure what is happening, which I think is really important, especially if we're trying to get people to change their behaviors. And then the pattern that we see on the test, whether the cortisol levels are high, whether the cortisol levels are low, whether they still have a natural diurnal curve, that helps us to choose the best treatment recommendations. And then when we repeat the test in the future, it helps us to know whether we're getting better and whether we're making progress. Next slide. So we have different ways that we can measure cortisol. You can just send them to the lab for a simple blood test, but it matters what time they go. So serum cortisol levels are normed for 8 a.m., which should be the highest point in the day. A lot of labs aren't even open at 8 a.m., so that's not perfect. And if the patient, and the level drops fairly quickly after 8 a.m., so if they don't show up until 10, 11, or if they don't go till the afternoon, then the results are really not so helpful. But most importantly, just the stress of getting to the lab, having a needle poked in your arm can affect your cortisol level. And we can only get one sample because they're probably not going to go back multiple times in the day. So to me, a blood cortisol level would be like the last option if there was just literally no other options. Another option is we can do a 24-hour urine. And this at least will give us more information because we can know the total amount of cortisol production over the day. We can also look at the metabolites, but we can't see the diurnal variation. So we can't see if they're following a natural rhythm where it's higher in the morning and lower later on in the day. And collecting a 24-hour urine is kind of a pain too. I, in fact, had a patient years ago who collected a 24-hour urine, and instead of just staying home to collect her urine, she actually put the container in her purse and took it with her. So I'm pretty sure you're supposed to keep it in the fridge, but nonetheless, she put it in her purse, took it with her. Of course, it spilled, and she had the whole thing of urine in her purse, and it was a total nightmare. But 24-hour urine is a little bit less convenient. Main thing, though, is we miss the diurnal variation. So saliva is better because we can get multiple samples over the course of the day. So we can get it done in the morning and a couple of hours later, and in the afternoon, in the evening. We can even do several samples first thing in the morning to see the spike that they get when they first wake up in the morning. So doing diurnal salivary samples is a perfectly good choice, and that's a good way of measuring cortisol levels. But if we do the dried urine samples, like in a Dutch test, we get the best of the 24-hour urine and the best of the saliva, because we can see the diurnal curve. We can see if they are starting off kind of low, going up appropriately, coming back down again. We also get the metabolites. We get the total amount in a 24-hour period of time. So it really kind of gives us the best of both worlds. So that's why I prefer to do the Dutch testing. I also find that my patients very much prefer to pee on a little strip than they do to have to collect the saliva when they have to spit in a tube. So I know that Precision Analytical, when they do their salivary testing, use salivettes, like that you just hold the little piece of cotton swab stuff in your cheek. And so that's easier, again, than having to spit in a tube. But the dried urine sample is really the easiest of all. Next slide. So what is a normal pattern for cortisol is that in the wee hours of the morning, we get this rise in cortisol. And right after you wake up, the cortisol level should go way up. So we should see that spike. And we can see it in saliva a little bit earlier than we see it in urine. It takes a while for it to get processed and to come out in your urine. But nonetheless, we see very similar in saliva and urine that the cortisol level spikes up shortly after you wake up, and then it drops down over the course of the day, and then it should be nice and low in the evening. So that means you should have energy during the day, and then you should be calm and relaxed and able to fall asleep in the evening. Next slide. And again, this is just the normal curve should go up and then it should go down. Next slide. So what we see a lot is that the curve is flattened. So the red dots are this individual's values, and you can see they start off not so bad. They're, middle of the range when they first wake up, but then the level is supposed to go way up, and it doesn't. It just goes straight across. So technically, each one of these values pretty much landed in the normal range, but the curve is very flat, and the curve is a really important piece of this. Next slide. We know that even if all 4 points land in the normal range, if the curve is flattened, there is a worse prognosis in breast cancer, lung cancer, ovarian cancer. Next slide. And also in cardiac events. Next slide. So I don't have my cursor here, but if you can see, there's DBP and SBP, kind of, yes, right in there. That's diastolic blood pressure and systolic blood pressure. So I'm going to admit to you, first of all, in order to understand this slide, I had to get my college student who's about to graduate with a statistics degree to explain this to me. But what they've done is they've looked at just all the regular risk factors for heart disease. And anything that is close together on the graph means that they're associated with each other. So we see diastolic blood pressure, systolic blood pressure, they're close together because we would expect if somebody's got high blood pressure, they probably have high both. If we go a little bit to the left, there's BMI, waist to hip ratio, and D is waist diameter. And those are kind of grouped together because, of course, you would expect if somebody's overweight, all three of those things are probably off for them. On our graph, the x-axis, so going from left to right, that axis is the most important. So things that are on top of each other matter more. So if we move over, we see LDL and CH is cholesterol. Those are on top of each other. And so that is significant that they are grouped together. So if you just kind of have a general look, things are mostly on the left. HDL is off by itself on the right. So this is just normal risk factors for heart disease. We know these things, nothing new here. Next slide, what they did is they separated out people who had a normal HPA axis, and basically it looks the same. It's not exactly the same, but the systolic blood pressure and the diastolic blood pressure are beside each other, and the LDL and the cholesterol are beside each other, and the waist diameter, the BMI, the waist hip ratio, it's beside each other. So it's very similar. The next slide, though, they separated out the people with a flat HPA axis. And what you can see is the people with the flat HPA axis, everything lines up exactly in a line on that x-axis, except for the HDL, which is an outlier way out there. So what they concluded in this study is that this was so significant that they proposed that the flat diurnal cortisol could be the underlying causal factor for all of these things. So the study can only prove association. It couldn't prove causality, but I think this is very striking that a flat diurnal cortisol curve was very strongly associated with all of these factors that we know are risk factors for heart disease. So we talked about people with digestive issues, gut health, we still want to think about HPA axis, but also people who have cardiovascular, cardiometabolic issues. Next slide. Okay, so let's go through some of our cases now. First case is a 40-year-old male bank executive who's stressed out all the time. Because he's stressed out all the time, he lives on caffeine and donuts, and so of course he's gaining weight right around his midsection, and he's like okay when he gets up in the morning, but he's totally wired at night, has a really hard time falling asleep. Next slide. And as you can predict, here's his Dutch test. So his metabolized cortisol up there towards the top is way too high. And if we look down towards the bottom, his 24-hour free cortisol is also way too high. And when we look at his curve, we can see he's the red dots, and you can see his curve is way too high. So this is a guy whose HPA axis is on overdrive. He is living in fight or flight, and this is interrupting his sleep. It's making him lose weight. It's pushing him towards cardiometabolic problems, probably pushing him towards gut problems, inflammation, etc. So we really want to help to work to calm this guy down. Next slide. So what we would want to do with all of our patients is we want to make sure that they're eating a healthy diet. So we need whole food nutrition, making sure that he's getting all the healthy nutrients that his body needs. Next slide. Of course, we want to avoid the things that are kicking his adrenal glands when they're down. So that would be things like alcohol, sugar, excessive amounts of caffeine, which is exactly what he's surviving on right now. Next slide. We want him to exercise, but generally speaking, when people have HPA axis dysfunction, we kind of want gentle exercise because exercise is a stress and it's a good stress. But somebody like him who's a real sort of type A person who probably thrived on stress for a long time is the kind of guy that's going to train for a triathlon or, you know, really go in hardcore competitive if he ends up getting there at all. So that's not what we're looking for. We're looking for walking, yoga, stretching, you know, physical movement, but not hardcore, high intensity, really competitive stuff. Next slide. Of course, sleep is extremely important for HPA axis function. And for somebody like this, when they're on sympathetic overdrive, sleep can be really challenging. So we do need to focus on sleep as a really important part of the treatment. And we would expect that his sleep will get better as his HPA axis improves. Next slide. So stress management is a key point, especially for this guy, because as far as we know, he doesn't have any underlying disease processes that are driving his HPA axis. It appears to be primarily from his life stressors. So as much as possible, we want him to do some stress management. And my experience is type A executives are like the last people that really want to hear about stress management. They're the people that need meditation more than anybody else, but it tends to be really, really hard for them to sit down and try to turn off their brain. So more than anybody else, though, this is the kind of person that really needs to institute regular stress management as part of their routine. And if we as a provider just say, you need to reduce your stress, that's going to get us nowhere. So what we really need to do for somebody like this is we need to give concrete instructions. We need to have a plan. We need to give them instructions on how to do breathing exercises or how to do some kind of a mindfulness program, get them an app on their phone. HeartMath is a great program for people to do. We need to give them instructions that you need to, do the breathing exercises for 5 minutes twice a day, whatever it is that we're going to choose to do with them. And they should have some say in it so they have some buy-in, but it needs to be very specific instructions because otherwise it's just not going to work. And one of the things that I found really helpful with my patients is getting them to download one of the apps on their phone. There's tons of them now. There's Calm, Insight Timer, Breathe, there's all sorts of ones. But somehow having an app, having a gadget is, that tells you what to do, you can follow instructions, it's a concrete thing. Sometimes that seems to be helpful for people. Next slide. So then there are nutritional supplements, of course, that we can use too. And we don't really have enough time today to go through like all the possible ways of treating HPA axis dysfunction. And we really want to look at the different patterns that we see on the test and see how we might treat them differently. So this is just going to be a quick overview. But phosphatidylserine is something that is really, really helpful, especially for people with high cortisol. What it does is, like this guy, his brain is sensing stress. And even when he gets home from work and he's sitting on the couch and he's watching Netflix, that brain message is still turned on the on switch, like danger, danger, danger. And what the phosphatidylserine does is it works at the level of the brain just to help put a dimmer switch on that to dial down the danger message so that his adrenal glands are not constantly being flooded with the message to pump out more cortisol. It won't make cortisol levels drop too low, so we don't have to worry about that, but it really does help a lot for some people with sleep. So it's especially a really great thing to have people take at bedtime to help with quality of sleep. Next slide. And this is just the study that used a specific phosphatidylserine and found that it normalized the response of the HPA axis to stress. Next slide. So herbal adaptogens are another good choice. These are herbs that have been used for thousands of years all over the world. So we've got lots of collective knowledge about the fact that they do work. And now we do have some science behind understanding how and why they work. But what they do is they help with homeostasis. So whether someone's too high or too low, or whether they're high in the morning and low at night, or low in the morning and high at night, or whatever their pattern is, herbal adaptogens can be helpful. Next slide. Interestingly, the molecule of these adaptogens is structurally similar to catecholamines and corticosteroids, which is what our adrenal glands are making. So I thought that was kind of interesting. But what they do is they activate heat shock proteins, and heat shock proteins are kind of like the repair team in your cells. So they're helping to keep your cells healthy. So they're helping to keep the cells healthier even under the effects of the stress. They tend to activate the SIRT1 gene. That's what's in resveratrol. That's how resveratrol does its action. And they also help affect nitric oxide levels, which is another thing that helps to keep our cells healthier. The adaptogens tend to inhibit MAOA and MAOB, which gives them antidepressant properties. And so that's another really interesting factor of how these herbs work. And of course, there are lots and lots of different herbs. We're just going to talk about a couple today. Next slide. One of the ones that I use the most is ashwagandha, which is an herb from Indian Ayurvedic traditions. And I really like this study because in this study, they gave the participants this ashwagandha. And the results are pretty dramatic. They showed a 70% reported reduction in depressive symptoms, 75.6% reduction in anxiety symptoms, and a 64.2% reduction in perceived stress. And that's really strongly different than what we found in the control group. Next slide. So the p-value was very significant, and specifically the serum cortisol levels were substantially reduced. So we are more and more having studies to help prove clinically how and why these herbs are helpful. Next slide. So here's what we did with this guy. We worked on his lifestyle. We gave him some phosphatidylserine. We gave him some ashwagandha. And within a month, he could already tell that he was feeling better. 3 months later, his cortisols are back to normal and he feels much better. It's not always that easy to help people, but he was somebody where he didn't really have a lot of underlying disease states driving the problem. He was just way stressed out. So if there's not really anything yet wrong other than way stressed out, then it doesn't usually take so long. It's relatively easier to help people. Next slide. Okay, so here's our second case. We got a postmenopausal lady who can't lose weight. She's been on bioidentical hormones for a few years already, but she isn't happy because she thought that when she went on bioidentical hormones, she was going to feel great and she was going to lose weight and life was going to be fabulous. And it didn't really turn out that way for her. She is quite overweight. She's about 50 pounds above her ideal weight, and she'd really like to be able to lose weight, but she hasn't been successful and she's tired. Next slide. So what we see for her is her metabolized cortisol is kind of at the high end of normal. So metabolized cortisol is an estimation of the total amount of cortisol that she's made. But when we look at her free cortisol is low. And on the graph, on the chart to the left, you can see that her red dots are just under the normal range for the first 3 of the day, and then she's back in the range at night. So she kind of sort of has a bit of a circadian curve, but it's pretty flat. And of course, everything is low. So the 24-hour free cortisol on the dial, that's just an average of those 4 points. So of course it's low. But sometimes if you just look at the dial, if it was high part of the day and low part of the other day, it might look fine, but of course it doesn't take into account the pattern, the diurnal pattern. So that's why it's really important to have that plotted out with our 4 different graphs. So this pattern that we see is a bit confusing, right? Her free cortisol is low and her metabolized cortisol is high. So if all we had done is a saliva test and we'd seen that flattened curve, we would think she was low. But it's not that her adrenal glands can't make cortisol. We can see that she's making it. It's just that she's metabolizing it all away. And the flattened curve is kind of more how she feels. So she's feeling tired. And we see this pattern a lot with people who are overweight and with people who are inflamed, you know, our cardiometabolic people. Next slide. So other things that we can do to help for people with HPA axis dysfunction: vitamin C, B vitamins, and magnesium. And we'll go through these a bit. Next slide. Vitamin C has been shown to help people respond to stress and help to lower cortisol. So a lot of times for people who do IVs, when we're doing our stress formulas, we put vitamin C in there. Next slide. And going back to vitamin C for just a second, vitamin C is the necessary ingredient that our body uses to make cortisol. So it's a necessary component for cortisol production. Pantothenic acid, or vitamin B5, is a cofactor for cortisol production. And there are studies on pantothenic acid and stress. So if anybody who speaks Japanese or Russian wants to read them and let me know what they say, I would love to know, but I am not able to find any studies in English. Next slide. Magnesium is something that's really important for adrenal function. And when we are stressed, it increases our body's need for magnesium. Next slide. And of course, here's just a whole bunch of other adaptogenic herbs. Ginseng tends to be one that's more stimulating, so helps maybe more with energy. Rolora is one that tends to be a little bit more relaxing. And oftentimes when we use these herbal adaptogens, instead of just using one herb at a time, we tend to use a mixture because when we use a little bit of the different herbs together, it tends to have an even better result than a big dose of one. Next slide. So what we did for Our Lady here is we helped to work on her lifestyle habits, just like we said before: healthy nutrition, stress management, gentle exercise, enough sleep. We gave her an herbal blend, and she did start to feel better within a few weeks. I found that when I first started my practice and I started prescribing bioidentical hormones, I had most people felt so much better, it was great. But I had a whole subset of people where, you know, we would raise their dose, lower their dose, change their dose. They just never really quite got all the way where they wanted to be. And it wasn't until I started addressing their HPA axis dysfunction that we really started to get the results that we were looking for. So that's a really important point. And anybody that does hormone replacement, if you are not including cortisol as part of your initial evaluation, if you're just looking at their estrogen, progesterone, testosterone levels, I really feel like you're missing an important part of the picture. And I see this a lot. People will go into the clinics that do just pellets, and that's all that they know to do is just insert pellets. But so many of the people that are coming in and they're not feeling good have cortisol problems, and you can stick pellets in them and lots of people will feel better. But sometimes you're just kind of band-aiding over their HPA axis dysfunction and it won't last. And sometimes they just don't get the results that they want unless we address this. Next slide. Okay, our next case is someone who is tired and constipated. We got a younger lady here. She's only 35, but she's gaining weight. She's tired all the time. Her periods have become irregular and heavy, and she's got this chronic constipation. Next slide. So when we look at her, she's got the opposite. Her metabolized cortisol is low, but her free cortisol is kind of on the high side. And when we look at the map, you know, where it's plotted out, technically all of those dots land in the normal range, but the curve is kind of flattened. And when we average it out, it looks like it's kind of high, but yet, you know, when you just eyeball it, it doesn't really look high at all on the free cortisol. So what we see here is this lady isn't really metabolizing her cortisol very well. She's spilling most of it free out into her urine. And this is a pattern that we often see with people who have hypothyroidism, that everything about their metabolism is slowed down, including their metabolism of cortisol. Next slide. So when we did her thyroid panel, in fact, we found that she was hypothyroid, and in fact, her TPO antibodies are high, which means that she has Hashimoto's. Next slide. So for this lady, really what we want to do is we want to address her thyroid function and her Hashimoto's, and then come back and see what happens with her adrenal function, because that's probably a big piece of the picture. And of course, we don't know which is the chicken and the egg, because if her adrenal function is not that great, that stresses her immune system and her microbiome and could put her at more risk of developing autoimmunity. But nonetheless, what we did for her is we helped, of course, with her lifestyle habits. You could give her some thyroid support, whether you're going to do that nutritionally with nutritional supplements, whether you're going to give her some desiccated thyroid. We can give her some adaptogenic herbs. And here I would say ashwagandha would be a great choice because it works on thyroid function as well as it works on HPA axis function. And the magnesium might be a great choice for this lady too because of her chronic constipation. And when we get her thyroid improved, we would also expect to see that the HPA axis should start to improve too. Next slide. And one more case here. So I see an awful lot of these people. Here we've got a 45-year-old single mom with 3 teenagers, which is like code for high stress. She wakes up exhausted in the morning, no matter how much sleep she got the night before. She has to press snooze a couple of times. She crawls to the coffee pot. She has to have caffeine in order to function. And she kind of makes her way through her day, but then in the afternoon she crashes and she either needs a nap or more caffeine or something to get her through to supper. She finds that if she doesn't eat frequently through the day, that her blood sugar crashes, she gets hypoglycemic, she gets lightheaded if she stands up too quickly, and she just feels completely overwhelmed trying to get through life. Next slide. She feels like she's just too tired to even consider exercising. And if she does go out and do some kind of activity, she ends up being wiped out and she just has to crash on the couch to kind of recover afterwards. She falls asleep, but she's tossing and turning. She doesn't get restorative sleep. Her periods are heavier. She's got more PMS symptoms. And she is trying her best. So she is trying to do some meditation. She's trying to eat better, but she's too overwhelmed and it's just not working. And the symptoms are really causing a lot of problems. Next slide. This is how she feels. I'm from Canada. I am from Manitoba, which is the polar bear capital of the world. So I have to include a polar bear slide. But I'm sure many of us have felt this way at some point, especially with all this coronavirus, working from home, all the stuff we've got going on. This is how she feels all the time. Next slide. So here's her cortisol pattern, and you can see her free cortisol is low, her metabolized cortisol is low, her, when we look at her on the curve, she's flat. Now, interestingly, I don't remember whether she was taking DHEA, because in her, we would expect that her DHEA level would be low, and we haven't really talked a lot about DHEA today, but I believe that she was taking DHEA as a supplement to try to help herself. And one of the challenges is if you take DHEA, that could cause a little bit more negative feedback on the HPA axis and make the cortisols even worse. So for somebody who's flatlined like this on their cortisols, we might want to support the cortisol first before we added in any DHEA. But we can see that in her HPA axis is kind of burned out, she's low across the board, and so of course she feels bad. She probably doesn't have Addison's, because that first morning cortisol, when we see that red dot, is normal. I have diagnosed people with Addison's on this. Typically their red dots are just flat along the bottom, and you would want to then send them on for further testing. But because hers is normal, that first morning dot on awakening, probably it's not Addison's. Next slide. So some of the things we could do to help her: licorice. It helps to reduce the breakdown of cortisol. It has some mineralocorticoid effects, and so it can help with blood pressure. So she gets lightheaded when she stands up too quickly. People with low cortisol tend to run low blood pressure, whereas the people with high cortisol tend to run high blood pressure. And when you don't have enough blood pressure to get blood pumping effectively to your brain, of course you feel tired and brain foggy, etc. So oftentimes people will feel better with some licorice, and salt too. If you get them to drink some salt water in the morning, that can actually help them a lot. has to be the glycyrrhiza, because deglycerinized licorice, which is what we use for gut health, won't work. It's the glycyrrhiza component specifically that we need here. Next slide. And you just have to be careful. People who have high blood pressure aren't good candidates for this, because if it makes their blood pressure go up higher, then they can run into troubles. Next slide. And I want to take a second to talk about adrenal extracts. When I first started addressing HPA axis dysfunction, I was very hesitant to use adrenal glandulars. I am an MD, and I can assure you that the word glandular was never spoken in all of my medical training. It just didn't seem medical. It seemed, I don't know, inappropriate, weird, old-fashioned. It just didn't seem right. So when I first started, I would give people a little bit of, herbal things, and, sometimes people got better and sometimes they didn't. But in going to conferences and talking to colleagues, I heard so many doctors talk about how much these adrenal extracts help their patients. And a lot of times it was the doctor themselves that was in functional medicine because their own burnout, and they themselves had taken these extracts and felt so much better. So having done this now for 13 years, my experience is these adrenal extracts are so incredibly helpful. For somebody like this who is just flatlined, everything is low, that would be one of my first go-tos. We don't really have a lot of medical research. We can go back and we can find research from like the 1930s, but that's not so helpful these days. But anecdotally, and from my personal experience, this stuff is extremely helpful. And how I explain it to patients is it's kind of sort of like Armour thyroid for your adrenal glands. It's like it's desiccated adrenals, kind of like we use desiccated thyroid. And the cortisol is supposed to be removed, so it's not supposed to have hormone in it, but it's got all of the other factors that can be really helpful. Next slide. This is just a super simplified version of how the different steroid hormones interact, just to show that both progesterone and pregnenolone can be precursors in the pathway towards cortisol. Next slide. So in this case, she is having heavier periods, she's having more PMS, and so we could give her some pregnenolone and or some progesterone to help with her menstrual cycles. And one of the reasons for women to have more menstrual problems and have more PMS is if they have HPA axis dysfunction. So the younger a woman is, the more likely it is that if we can just solve her HPA axis issues, that her menstrual issues will get better. Next slide. So what we did for Our Lady here, of course, we helped her with lifestyle factors. We gave her an herbal blend that included licorice, and we gave her adrenal extract. And then we also gave her some progesterone during the luteal phase of her cycle. Next slide. So a month later, she's sleeping better, although she's still not really getting sound sleep. She's not as tired. Her periods are getting better, but she's still not where she needs to go. Next slide. So she is somebody who almost certainly has underlying factors. It's not just life stress. Her stresses have been going on for a long time, most probably. And so we would want to be digging to get to the root. So we want to think about food sensitivities and gut problems and toxins, things like mold and metals and other kinds of chronic infections, autoimmune disorders. So here is somebody where just addressing their HPA axis and trying different herbs and different supplements may not really be the answer. And we probably need to do a full-on functional medicine evaluation to get to the root of what's dragging her adrenal function down. Next slide. So HPA axis dysfunction is not looked for in regular medical offices. It is not diagnosed. Even if it is recognized, it's not treated. I had a patient who on her own purchased a saliva cortisol test. It was very flat, but when she took it into her doctor, of course, he didn't know what to think about it and just poo-pooed it away. And when she finally found me and we got her feeling better, she went back to that same doctor to say, I feel so much better. I've lost weight. I've got my energy back. I can go back to work. And he just sort of scoffed at her and told her that when she lost weight rapidly, that it was just going to come back again. And she ended up leaving in tears. So I don't really feel like it's the doctor's fault. It's that we are not taught this at medical school. We are only taught Cushing's and Addison's and nothing in between. And a lot of these symptoms are so common that we just think they're normal, right? Needing coffee in the morning or feeling tired in the afternoon or not sleeping. But we can help these people, and it's really important. And especially know that if you've measured someone's cortisol level, but what you're doing isn't working, you really need to look for the underlying factors, because there are so many things that can contribute to HPA axis dysfunction. So that's where a functional medicine approach can be so important. So that's what I've got, and I'm happy to answer questions, Amy, if there's any questions.
There is. So let me scroll on up here and we'll start asking some things of you.
Okay.
So do you have any telomere tests that you recommend? I know at one time I think there were a couple tests out there in the world, and I don't know whether they still are, or do you ever test the telomeres?
Yeah, that's a good question. I personally have not tested telomeres. And the reason that I haven't tested telomeres is because I guess I feel like the things that we're going to do to make your telomeres better are all the things that we're going to do anyway, right? We're going to help reduce your stress and help you to exercise and get your hormones balanced and your gut healthy and all that stuff. And I don't know that we expect your telomeres to grow longer. I think what we're trying to do is just slow down the rate that they are shortening. And I'm not sure how we can measure that over time. So the one time that I think it might be helpful is if we're trying to convince someone of the error of their ways and we want to try to help them to, make some healthy changes and show them how their body is aging in an unhealthy way. But I believe that SpectraCell had been doing telomere testing, but I'm not sure that they
Correct,
still are.
that's what I recall too.
Yeah, but I don't know because it's not something that I routinely do.
Yeah. So do you typically ask your patients to stop adaptogen, herbs, pregnenolone, DHEA supplements before they test, or do you, specifically if you've prescribed and maybe you do a retest?
Yeah, that's a really good question. I don't typically, so especially if I'm doing a retest, I guess my thought process is if I've given them some adaptogens and now I want to know, how they're doing, I usually just leave them on the adaptogens, because if they are looking good, then we can try stopping the adaptogens. If they still don't look good even on the adaptogens, then I know that that it's not really working. Whereas if the adaptogens had been helping and then they stop the adaptogens and it changes the test and it doesn't look as good, I don't really know how it looked on the adaptogens. I don't think there's a right answer. I honestly don't know that if you had them stop it for a short period of time, it's really going to change the test, because it's not like you take your ashwagandha in the morning and it affects the cortisol level in the afternoon. So I don't really know how much of a difference it would make. And I don't necessarily tell people to stop them.
And you might have touched on this, but I'm going to ask it again. So what's your go-to supplements to either decrease waking cortisol or increase waking cortisol?
So I would say my number one supplement for people who are low in cortisol would be adrenal extracts. Just because those are the ones that people like so much. And 6 months or so down the line when they're feeling better, I start saying, well, maybe we could stop them and see if you still need them. And then they'll say, no, I like this one. It makes me feel so much better. I don't want to stop. And then in terms of lowering, I would say probably phosphatidylserine would be my number one choice. And my number two choice actually would be supplements that contain Relora. It's a magnolia extract, and it really does seem to do a good job of calming the HPA axis.
Okay, so I've got a question here that sort of gives a patient scenario, and they're just wondering what your thoughts are. What if I have a patient with low 6 a.m. and 8 a.m. cortisol in urine, but high cortisol in the evening, wakes up at 3 a.m. and stays awake, so then needs naps throughout the day? How would you approach that patient?
Yeah, that happens a lot, right? Is that they're high at the wrong time and low at the wrong time. We see this all the time. So here's where I would use adaptogens, because the adaptogens help the homeostasis. So it'll help bring the cortisol up when it's too low, and it will help bring it down when it's too high. So you just maybe want to avoid ones that are more stimulating at bedtime. So if you've got some that have more ginseng in them, maybe those aren't the best blends to use at bedtime. But maybe that would be a good one to use in the morning if they're tired. But as a general statement, I would say adaptogenic herbs would be my go-to for somebody who's too high some of the times and too low other times.
Great.
Which happens all the time. That's really common.
Can you take ashwagandha with antidepressants? I don't know if you
yes.
Okay. Good. What is the clinical significance of metabolized cortisol and how do we treat it? You might have touched on that with your case study.
Metabolized cortisol is giving us an estimate of the total amount of cortisol that they made that day and then metabolized in their clearing. So if the metabolized cortisol is low, that's suggesting to us that they're not making a lot. Whereas if the metabolized cortisol is high, it's suggesting that their body is overproducing. When we look at the free, we sort of have to look at the free cortisol too. And so if the free cortisol matches, so if their free and metabolized is low, we know they're not making a lot. If their free and metabolized is high, then we know they're making too much. So that's easy. The tricky part is if one is low and one is high. So that's where it gets complicated. So if the metabolized cortisol is low, but the free cortisol is high, that means that they're not really metabolizing their cortisol well. That's when we usually think about what things slow down metabolism, like hypothyroidism. And if the metabolized is high, but the free is low, that is what we commonly see in people who have obesity, inflammation, chronic stress. So it's important to recognize the patterns in order to be able to understand both how to treat and what underlying factors you need to be looking for. But it's confusing, especially when they don't match.
So what dose and form of magnesium do you typically prescribe?
That's a really good question. So if somebody, it depends why I'm using it. So, and oftentimes we look at what their other symptoms are. So in the example that I gave, that person was having a lot of constipation. So magnesium citrate tends to be great for constipation. We use a lot of magnesium malate. You can use magnesium glycinate. For people who are not sleeping and they have, their brain doesn't turn off and they're really anxious and they just need to calm, magnesium threonate is really great because it gets more to their brain. So any chelated magnesium will be good because that means it's better absorbed. The one to avoid is magnesium oxide because the oxide form is not well absorbed, and as you give them a higher and higher dose, it'll just cause diarrhea. So any of the chelated forms, anything that's not oxide, the one with the X.
Okay.
And then the dose that was asked too, again, it totally depends on what the person's gastrointestinal tract can tolerate. So I would say you would usually start somewhere around 200 to 400 milligrams. For people with constipation, though, sometimes we go a lot higher than that.
Okay. So I've got kind of a question here on HRT a little bit. I've got a practitioner here that wants to know what your typical timing of doing the Dutch test when a patient's starting on BHRT, which I would imagine do you do it 3 months into their therapy? She says that she asked because when she started using Dutch a few years ago, she would do Dutch testing before they started HRT, and obviously if she did, was getting the estrogen metabolites, they'd be undetectable typically there. And therefore she transitioned to waiting until on HRT for 2 to 3 months before ordering the Dutch. But she did mention, it kind of goes to your point there, that the downside is that I'm not getting that cortisol info at the beginning.
Yeah, so I measure the adrenal cortisol panel always in the beginning. I'm sure that I could find some exception, but as a general rule, I always measure the adrenal cortisol panel in the beginning. For women who are premenopausal, then it's great to measure the whole thing, right? Because you can get the metabolites, oftentimes are estrogen dominant, so that's easy. So the ones where it's a question mark are the postmenopausal women when their estrogen level is really low and then the metabolites aren't so accurate. So on the one hand, it costs the same to do the test and ignore the metabolites. If you know that they're not going to be so accurate. So you could do that. The other thing that you can do is you can just order just the adrenal part of the test. And then once they are on HRT and you've got more estrogen so you can measure how they're metabolizing it, then you can do the whole panel 3 months later, in order to see the metabolites too. So either way.
Right, and I think that's what I would recommend too, is to start with the adrenal and then do the whole panel once you've had them on HRT to see where the estrogen levels are.
But it is
So
correct
let's see.
and I think that's an important point, that if someone's menopausal and they barely have any estrogen, because the metabolites are looking at like the percentages, because we're working with such small numbers, you know, it's hard to be accurate. So we shouldn't get too bent out of shape if the metabolites don't look quite right, if there's really hardly any estrogen in their system.
How do you know when to support pituitary versus adrenal glands with glandulars?
That's a good question. So I suppose for pituitary, we've got all kinds of things that we can measure. So we can measure their LH, FSH, ACTH, TSH. So if somebody had a picture where all of the pituitary hormones looked like they weren't so great, then I might think more of that. Otherwise, I guess typically the supplements that I use mainly, you know, we mainly focus on sort of the HPA axis as a whole or on adrenals as opposed to pituitary. And I haven't specifically gone out to try to treat the pituitary separately. So
do you typically avoid licorice with patients that already have high blood pressure?
yes, absolutely.
Okay. This
It's a
particular question, they said they've seen articles that indicate that it takes higher milligrams of licorice than what is in most combo adrenal products, I guess, to affect the blood pressure.
Yeah, I've had patients who had kind of just high-ish blood pressure, you know, like, I don't know, like 135 over 90. And then I've given them licorice and they end up not doing well. They get puffy, they get headaches, their blood pressure goes up. So I've seen it happen. So I would say there's a million things that you can choose from. And so I would just stay away from licorice in people with high blood pressure, and then you don't have to worry about it.
Okay, so staying kind of on that licorice theme, if licorice is contraindicated in a patient with a depressed...
Oh, I lost you. Are you still there? I can't hear you.
cortisol curve and hypertension, what can be used?
I'm sorry, I lost you, and I heard the... Yeah, I can hear you now. I can hear you now, though. Can you hear me?
Can you hear me now, Dr. Matthew? Okay, you got me. So yes, I can hear you. So
okay. I'm sorry, though, I didn't hear the question.
So let me ask this question again.
Yeah.
Okay, so the question is, if licorice is contraindicated in a patient with a depressed cortisol curve and hypertension, what can be used?
Okay, so for somebody who has low cortisol and we're trying to boost them up, you can use adaptogenic herbs. If they're really tired, ginseng is one of the more stimulating ones, but ashwagandha can be helpful, holy basil, rhodiola, there's all kinds of different ones. And usually what you would end up doing is you would just find a really good professional company that has a blend of these different herbs in it. Another really good thing to do if you need to boost up cortisol is the adrenal extracts. And that, out of all of them, is the one that people find, in my experience, that they can notice a difference. So there's no one thing that works perfectly for everybody. Some people do better with the herbs, some people do better with the extracts, but those would be two things that work really, really nicely.
Good. Can you repeat your licorice dose range too?
Oh, you know what? I can't tell you that one off the top of my head. I'm sorry. I'm so used to just using what we use. It's on the slide though, so when it comes out, I had looked it up for the slide. I'm sorry.
Okay. Thoughts on dried urine results with low normal metabolized cortisol, low normal DHEA, but normal HPA axis and free cortisol?
So if the free cortisol looks okay, but the metabolized is low normal, I would still think about the same things that cause the metabolites to be low. Like maybe the thyroid isn't that great, the metabolism is slowed down for whatever reason. I would still support their adrenal function. And actually, one of the things that I like about the Dutch test is you get more different things that you can look at. Like we didn't even talk about the cortisone to cortisol conversion. But when you're talking to a patient and you're trying to explain why they're feeling the way that they're feeling, you can find different things that aren't quite right. So even if not everything is low or not everything is high, it's less helpful if you do a saliva test and everything lines up and looks in the normal range, but you don't have the metabolized cortisol to know that something actually wasn't so great. So it's common that one of them will look fine, the metabolized or free will look fine, and the other one's not so fine. And so, we would just address whatever the things are that we see, but definitely you'll see that all the time, that one might look okay and the other one, maybe it's not terrible, but it's not as good as it could be.
Good. Can you discuss a little bit more about the relationship of cortisol to DHEA?
Yeah, so cortisol and DHEA, of course, are both made in your adrenal gland. And when we have acute stressors, both of them can become elevated. But cortisol is, it's our primary stress hormone. So it's the one that is a survival hormone. And as a general oversimplification, your body will put its resources into making sure that it makes enough cortisol at the expense of your other hormones. So whether it's progesterone or DHEA, or if you're postmenopausal, testosterone, etc. So generally speaking, initially the cortisol and the DHEA will both be high, but the DHEA tends to drop lower first. And with age, cortisol tends to go up and DHEA tends to come down. So there's all kinds of different factors that affect the levels of each of them. So it's sort of hard to predict exactly what you're going to find. The one thing that I would say is if the cortisol is low and I've said that backwards. If the DHEA is low and the cortisol is high, you would want to give cortisol to have a better balance, because cortisol is a wear and tear hormone. DHEA is a build and repair hormone. And how I usually say it to my patients is cortisol ages you prematurely, whereas DHEA is an anti-aging hormone. So you want to balance. If the opposite is true, though, if the cortisol is low, well, I guess it's not opposite, but if the cortisol is low, you don't want to have the DHEA to be high. Like, you don't want to give them a lot of supplements to make their DHEA level be high, because at least theoretically, that DHEA could have some negative feedback inhibition on the HPA axis, which could result in even further lowering of the cortisol. So what I would typically do, if they're both low, sometimes what I do is I get them started on some kind of adrenal support, whether adaptogens or something, for maybe 4 weeks, and then add the DHEA just to avoid causing a problem.
Okay.
I would say I do it all the time, but
I've got one last question. When would you choose pregnenolone and when would you choose progesterone?
Yeah, that's a really good question. In my practice, it is my habit, custom, I don't know, I'm just used to using a lot of progesterone, because most of the people who come to see me come because they've got hormonal issues. And so I probably use progesterone a lot because I'm addressing, their PMS, their perimenopause, their menopause. So I use progesterone a lot more than pregnenolone. Some people don't tolerate progesterone, though. They just don't feel good when we give them progesterone. But usually they do fine on pregnenolone, or maybe they really don't have any problem with their progesterone. Their periods are fine, their progesterone is fine. Then I would go for pregnenolone. And older people, pregnenolone tends to decline with age. So for older people, especially when we're not going to be using HRT, pregnenolone would be a good choice there too. But some providers use pregnenolone as one of their go-tos. And I've talked to lots of patients who really feel better, like that pregnenolone has really helped them.
Okay, good. So that's going to be it for our questions. One thing I want to mention to everybody who's still on, one of the things that I mentioned at the top of this hour, and Dr. Matthew also mentioned, is, we know a lot of you are all practicing now virtually, a whole different way to practice medicine and see your patients. And just want to remind everybody, our team's here to support you with your virtual clinics now. We will drop ship directly to patients. No shipping charge, no upfront payment or anything. And again, I can't stress enough, we've got a great consulting team available to help with all the test results that you get back with your patients, to help you with treatment, how to interpret the results if it's a tough patient. Similar, Dr. Matthew went through some tough cases here this afternoon. So we're here to support you any way we can during all of this time in practicing virtually with your patients. So I want to thank everybody again. specifically thank Dr. Matthew for an excellent lecture, and hope to see you guys all again on April 29th, where Dr. Jones will be dedicating an entire hour to going over patterns, which, as you heard Dr. Matthew mention as well, understanding the patterns, the cortisol patterns that are going on with your patients are so important in understanding how to treat and what's going on with your patients, and potentially not just their cortisol levels, but their hormones as well. So thanks again, everybody. Thank you, Dr. Matthew.
Thank you. Take care.
Mm-hmm.